surveillance section, so I will give you the floor first. And then we're going to have Dr. Catherine O'Brien, Director of the WHO's Department of Immunization, Vaccines and Biologicals. So welcome to the three of you, and we start with Dr. Bruno Ciancio for ECDC. The floor is yours.
Hello, good afternoon, and very, very delighted to be speaking to this committee today. So today, if I can have my slides, please, I'm going to present you, next please, I'm going to talk about what we currently know on the variants of concerns of SARS-CoV-2, how these variants are spreading in the EU, and also actually what can be done to mitigate their impacts and also address future threats. Next, please. Now, COVID-2 is an RNA virus, which means that anytime he replicates, there is a chance for errors to occur, and therefore mutation may appear anytime. Fortunately, not all these mutations are leading to concerning variants. Many will just disappear or circulate without any public health consequence. For a variant to be considered of concern, it has to have an impact on the transmissibility of the virus, on the severity. It has to cause a change in the epidemiology or the clinical presentation, or it has to have an impact on the effectiveness of the public health measures that we are using, or on the diagnostics, treatments, or vaccines. There are currently 3 variants that are of concern in the European Union. The B117, also called based on where it was identified first, the UK variant. We have the B351, which is also known as the South African variant, and then the P1, first identified in Brazil and Japan. Next slide, please. Now, these variants are not all the same in terms of their characteristics, but they share many things in common. So the British, the B117, first identified in the United Kingdom, is definitely more transmissible than the earlier circulating variants. This is considered to be up to 75% more transmissible, and also it can generate more cases once one case has been in contact with other people. So we don't know yet if it is causing a direct impact in terms of severity. However, due to the high number of cases, it has led to increased hospitalization and severities in several countries. We have no evidence that this variant is causing problems in terms of immunity acquired through previous infections, nor through vaccination. The variant identified first in South Africa is also more transmissible, about 50% more transmissible. We have no data on the fact whether it is more or less severe. And there are reports of decreased protection from previously generated antibodies. So there could be also a risk for reinfection, although this needs to be confirmed by studies done on the actual population. And finally, the P1, it's not very common yet within the EU, as I will show very shortly, but it is definitely more transmissible. And here we have also evidence that it can cause reinfection of previously infected people. Now, so far in the EU, the UK variant has been identified in basically all countries. The South African has been identified in 18 countries, and the Brazilian in 9 countries. Next slide, please. So overall, you can see that according to our activities of epidemic intelligence in ECDC, we have identified 24,000 cases of 117 variant, 900 cases of the so-called South African variant in 18 countries. Some of this is related to travel, so people have been returning from countries where the South African strains was more widespread, but there are also reports of outbreak and community transmission in some countries. For what concerns the P1, we have been, about 200 cases have been identified so far. Most of these have been linked to travel. However, this variant is particularly concerning, as I told you before, and we have now the initial evidence of some clusters appearing in some European countries. Now, these numbers that you see here are an underestimation of the true number of cases, and I will show now in the next slide also why this is the case. Next, please. I mean, first, let's look at the distribution of these three variants within the various countries in the EU. The first row indicates the UK variant. You see that in all sequencing a sufficient number of cases, there has been a progressive increase in the proportion of variant viruses among all viruses that have been sequenced. See, for example, Denmark, who is a country that tested quite a lot, a sharp increase over time. This is similar to what happened also in the United Kingdom, where it took about 6 weeks for the variant to become the dominant strain. Now, the row in the middle is the South African variant. You see here it's present in some countries, but is not yet becoming anywhere dominant. And the row below shows the distribution over time in various countries of the Brazilian variant. But again, if you look also at the recent weeks, there are no signals of increased prevalence of this variant. Still, we need to monitor this very, very closely. Next. One important message is that even if these variants are more transmissible, they respond to the same measures that we used and that we are using for the normal virus. The thing is that being more transmissible, such measures need to be strengthened. Now you see here the example of what happened in Denmark. On the left-hand side, you see the epi curve in red. And there was a significant increase of cases between December and January. Never seen before, actually, in Denmark. Still strengthening all the public health measures, strengthening contact tracing and cluster identification really allowed the country to bring down the numbers to lower level of transmission. So this is an important message. Next slide, please. Now, here I would like to show you that in Europe, in the European Union, we are strengthening our ability to identify and monitor variant viruses, but we are not yet there. In the week 7/8/2021, which is the week ending at the end of February, you see that only 9 countries are sequencing at a level that is sufficient for detecting and monitoring the emergence of these variants. So we have quite a number of European countries that are not able at the moment at a level that would enable them to rapidly identify and monitor, and therefore also control variants of concerns. Next. Here it is encouraging to see that over time the capacity in various member states is increasing, but many are still far from the target. The target is shown by the blue lines and up per each week. And you see that several countries are still far below the target that they need to achieve in terms of sequencing per week. Next slide. Now, ECDC, together with the European Commission, we are putting in place an important program to strengthen whole genome sequencing in member states in order to enable them to monitor and control, actually, the emergence of variants. Here is one type of support that we are providing. Basically, we are offering sequencing to countries that are having problems. And we started this service now in February, and until last week we received more than 3,000 samples from member states to sequence, and we aim to increase this progressively also with the financial support from the Commission and go up to maybe 15,000 or even more sequences per week. However, this is not sufficient, and we really need to strengthen member states' capacity in a sustainable way. And this is what you will hear later on from the European Commission when they will introduce the HERA incubator proposal. Next slide, please. Now, the real, to summarize what we can do in terms of controlling the emergence of these variants, it is obvious that the main things that we have to do now is to strengthen the public health measures. The same measure need to be complied to a higher degree in order to get the same results that it had before. And we need to be able to identify and control outbreaks and also learn from reinfections and vaccination failures to understand how frequent these are and whether these cases are able to also transmit there. But most importantly, or equally importantly, we need to increase the rate of vaccination and put our vulnerable population under protection as soon as possible. Next, please. And we actually published in February an important model where we show what will be the impact of continued public health measures in combination with optimal vaccination strategies on mortality, assuming that there is a variant circulating that is 70% more transmissible. Now, the figures in terms of mortality may not be accurate because they're based on a model. However, the dynamic that you see here is quite reliable. So if the public health measures are strengthened and continued at least until the beginning of May, and in the presence of optimal delivery and vaccination of the population at risk, we will have a significant delay of the peak of mortality. And also the peak will be much, much lower compared to all the other scenarios that we have tested. Next. So I would like to thank you for your attention, and I'm happy to answer any question you may have.
Thank you. Sorry. Thank you very much. We move now to the second panelist from the EMA, Dr. Marco Cavalieri. Floor is yours.
Please, Mr. Cavalieri, press the speak button in order to take the floor. Thank you.
Thanks to you, and good afternoon to all of you. I hope you can hear me well. It's my pleasure to be here to tell you what is the perspective of the EMA on the development of vaccines for the emergent variants for SARS-CoV-2. So if I can have my slides. Next slide, please. So as Dr. Chancho's already illustrated what is a variant, for me just here to mention that a variant is a strains of the virus that has different phenotypic characterizations, and in particular one of these is the antigenicity, so how it responds to antibodies and the immune response in human beings. And that's one of the characteristics that, of course, we are looking into when talking about emergent variants and impacts on vaccines and monoclonal antibodies. Next slide. And I think he already described which are the main variants that are currently circulating that are of concern, so I don't have to enter into the details here. Next slide. Now, talking about what data do we have with respect to how vaccines are performing in the face of these emerging variants, I will start with a bit of bad news. This is a small study conducted in South Africa with the SHADOX1 vaccine, so the AstraZeneca vaccine. And here in this study, which again was not a big one, was around 2,000 individuals recruited, this study did not show any efficacy of the SHADOX1 vaccine in terms of mild disease in a situation in which the so-called South African variant was the main virus that was circulating at the time. So this data would raise a bit of concern with respect to the ability of the vaccines for SARS-CoV-2 in order to prevent COVID-19. However, it's important for me to stress that, again, here we are talking about mild disease in a small study, and we don't know whether protection from severe disease could still be retained by this vaccine, and we would need more data in order to ascertain the capacity of this vaccine to still be protective, which we cannot exclude at this point in time. Next slide. Other data that have been emerging are this one from the recently approved vaccine from Johnson & Johnson that the EMA gave a positive opinion last week and was approved in the European Union. This vaccine also has been studied in a large clinical trials that recruited subjects in various parts of the world, including Brazil and South Africa. And as you see here on the slide, essentially what they've seen is that in South Africa, at the time when the South African variant was the main virus circulating, still there was protections demonstrated, both in terms of protection from moderate disease, but also importantly for severe disease. And in terms of protection from severe disease, the level is pretty similar to what we've seen in other parts of the world where the original ancestral strain was circulating, like the United States. So this is really good evidence and rather reassuring on the fact that this vaccine could still protect from COVID-19 due to the new variants. Next slide. Also, another vaccine that is not yet approved in various parts of the world but already delivers some results is the Novavax vaccine. This is a subunit vaccine with an adjuvanting system, and they conducted studies both in the United Kingdom and in South Africa. And in the United Kingdom, with the B117 variant being the majority of the virus circulating, they demonstrate really high efficacy, 90% overall, which is a really remarkable results. But even in South Africa, with the South African variant that we know is much more insidious in terms of escape from the immune response, the level of protection was around 60%, which again is a very good signal on the fact that these vaccines are able to protect in a good way against such a variant. Next slide. With respect to the messenger RNA vaccine, probably the most relevant information that has been emerging a few days ago are the data from Israel, where, as you know, the B117 variant is now predominating, so it's the major strain that is circulating there, and they really show good effectiveness of the Pfizer-BioNTech vaccine. But here what I'm showing is the level of cross-neutralization in the laboratory from antibodies generated in subjects that were vaccinated either with the Moderna vaccine on the left or with the Pfizer-BioNTech vaccine on the right. And what you see here, well, first of all, top left, that with the Moderna vaccinated individuals, the level of cross-neutralization to the B117 variant is almost complete. So you achieve the same level of cross-neutralization, which is a good indicator of the fact that this vaccine will be equally protective against the B117 variant. But if you look below there on the left, you see that the level of cross-neutralization against the South African variant is somehow reduced. We are talking about approximately 6-fold reduction. Nevertheless, there is still a very high level of neutralizing antibodies in there, so we would expect that the vaccine will still be able to protect against the South African variant. And a similar kind of dissertation can be taken on board for the Pfizer-BioNTech vaccine that you see here described on the right, the level of cross-neutralization against the South African variant, which, as you can see, is somehow reduced with respect to the ancestral strain, but not to a level that really there is abrogation of the humoral response or the cross-neutralization of the antibodies, which again is a very good signal of the fact that the vaccine will be able to retain protection against this strain as well, even if, of course, for the South African variant, we have not yet any proof in the field in terms of either clinical trials or observational study with respect to what is the level of protection with the messenger RNA against the South African variant or the Brazilian variant. Next slide. So in the face of these emerging variants, one important point that we as regulators discuss in a very proactive way is how can we rapidly approve new version of the vaccines that are already approved but that are incorporating the variant strains. And in order to do that, we started having a discussion with international regulators and with the WHO, and we come up in a workshop with international regulators under the auspices of the ICMRA with a common agreed position on the way forward for the development of such vaccines that would address the variant. And after that, the EMA has released a reflection paper that described the requirement with respect to what we need to see for in terms of manufacturing and clinical data before we can approve such variant vaccines. And after that, we also entertain a conversation with the marketing authorization holders of the vaccines already approved in Europe in order to agree on the way forward and to come up very swiftly with a potential approval of these variant vaccines with sufficient evidence on safety and efficacy. And also very importantly, that we have the chance to support the legal and regulatory framework that has been put up by DG Santé, and the legal proposal is expected to be launched soon, and we are very much supportive of this as we think this will create the right condition for being flexible and swift in coming up with regulatory decision on the approval of variant vaccines. Next slide. So another important aspect that we discussed is that which variant to include in the future vaccines. And this is something that really we would like to have a good understanding and a good justification by the sponsor of this vaccine on which strains they intend to include into the future vaccines. And this should be based on a good understanding of the disease surveillance and the characterization of the strains that are circulated at the time of the selection of such variant. But also importantly, would we think that it's necessary to have a global forum that should be established like under the WHO in order to make a global recommendation on which strains should be incorporated in any future variant vaccine. Next slide. So going into the details of what we put in our reflection paper, essentially on the clinical side, we would expect that the demonstration of efficacy and safety will come from smaller clinical trials that essentially will look into bridging the immunogenicity from the original vaccine that has demonstrated efficacy in the field in terms of protection from COVID-19, and that will be sufficient in order for us to derive enough information to say that the vaccine will be protective. And there are two settings in which this will be done. First of all, after primary vaccination with the variant vaccine, and to compare it with primary vaccination with the ancestral strain vaccine, and then in a booster setting scenario in which a single shot of the new variant vaccine will be given to subjects that receive a primary series with the parent vaccine, and then compare this also with homologous boosting as needed. So these small studies will be sufficient in order to determine, based on immunogenicity outcomes, so essentially the amount of neutralizing antibody, whether the new variant vaccine is supposed to be effective and can be approved, and will also generate sufficient amount of safety data. Next slide. Other important aspect that we are discussing is that there are a number of vaccines that have not yet been approved but still are under development and might be ready to conduct large clinical trials later on this year. So the problem here is whether these vaccine will be able to conduct placebo-controlled trial, considering that at least for a risk group, vaccination campaigns are ongoing and there are recommendations for those risk group, and therefore it might not be feasible to conduct placebo-controlled trial, at least in those populations. So it's something that we have to reflect on. And also importantly, the feasibility of clinical trials that will be looking into non-inferiority for clinical efficacy to authorized vaccine may also not be straightforward, as the amount of data that would need to be collected can be quite big and not easy also to derive sufficient amount of evidence that would give us enough information to say that non-inferiority is demonstrated. And based on these two elements, we do believe that we have to look into the possibility of conducting non-inferiority study using the immune response as the primary outcome. Of course, for this, it would be ideal to have immune correlates of protection established, which we don't know yet when this will happen, if ever. But nevertheless, we could still use immune markers in order to make this bridging. Of course, taking into account the platform technology and taking into account that such comparison should be done in a way that is interpretable and will give us sufficient evidence on what could be the level of protection that can be inferred from such comparison of the immune response. And at the moment, we are working on such scenario, again, working with international regulators and discussing with developers. So I think I will stop here. Thank you very much.
Thank you very much. We move now to the third panelist, Dr. Catherine O'Brien from WHO. Dr. O'Brien, you have a presentation to be added, to be circulated, but it will be shared with the members a bit later, as it was sent a bit late, so the IT team is still trying to have it live. Okay, so we are going to start now with you, Doctor, and then we'll try to connect your press live.
Yeah. Miss O'Brien, please push the speak button. Miss O'Brien?
Yes, I'm. Can you hear me now?
Yes.
Yes, it's okay.
Excellent. Thank you so much. Thank you for this important opportunity to bring the view of WHO on the COVID variants and vaccine efficacy regarding the new variants. It has been, I've been able to participate in part of the speakers' sessions before me, so it goes without saying that we have three main variants of concern right now as defined in the WHO framework around either impact on transmission, disease severity, or impact on COVID-19 countermeasures. And the evidence at this point supports the ongoing use of the existing vaccines, with some concerns about the B1351 variant with some of the vaccines against that variant. I think it's important really to thank you, to just reflect that we are in a place where there is an urgent need for a coordinated approach on surveillance and evaluation of variants and their potential impact on the response of the vaccine to the countermeasures. So next slide, please. We can just pass this one. This was my opening comment. Thank you. So here are the three variants that we've reviewed already, and clearly their distribution is spreading around the world, although that doesn't imply that for any given variant, it's the dominant variant within the world. Next slide. the previous speaker went over some of the specific data. What I'd like to do here is just highlight in a table across these 3 variants and across the products that are being used around the world right now, how much data is actually available either for clinical outcomes from that variant and a specific vaccine, or how many studies there are on laboratory aspects of the assessment of the variant and the particular product. I think what's notable about this table is how much blank space there is. There are some variants and some products for which there is, in a very short period of time, recognizing we've only been accruing this evidence over a period of a short number of months. But it really emphasizes that the data are growing, but they really remain incomplete. And the interpretation of these data is therefore has to be recognized as being not final interpretation. And you'll note here that there are parts of the evidence that are not in the public domain in a full way. They're through media reports only, or they're being presented in regulatory or policy fora and are not available for full community to deliberate on the evidence. Next slide, please. Just zeroing in on the B1351 variant, the variant first identified in South Africa, if we look across a variety of the vaccines, there is quite a bit of evidence, certainly more evidence on the neutralization activity in laboratory assays compared with the clinical evidence. And in that second column, I'm just comparing the clinical efficacy results over onto the third column in global studies of efficacy. So the South Africa efficacy, where the B1351 was circulating, compared with the evidence from a more global perspective. And it is indeed the AstraZeneca product with this small study that was emphasized already that recruited younger people. It recruited nobody in the elderly age group and only had mild and moderate outcomes. And there is pretty clear evidence from both this product and other products that efficacy improves, the value increases as the severity of disease increases. So we really have no measure of the B1351 efficacy in a severe disease outcome, and yet there is a plausible pathway through which this product would be providing protection against those severe outcomes. Next slide, please. So just with respect to the considerations of the AstraZeneca product and the variants, I think it's clear that for the B117 variant first identified in the UK, that there is a limited reduction in the neutralization antibodies and perhaps some limited reduction in vaccine effectiveness. But for the B1351 variant, I've highlighted here that at the SAGE meeting, WHO's recommendation is that the use of this product should be used according to the prioritization roadmap, even when variants are present in a country, and that countries could conduct a benefit-risk assessment according to the local epidemiologic situation and product situation in the country. So we continue in SAGE to look at this variant and this situation. Next slide. So just with respect to the approach to monitoring and assessing the variants and their impact from a WHO perspective, next slide. We do see that a coordination mechanism pulling together the monitoring of surveillance, clinical presentation, viral evolution through a forum, a variant forum, determining those variants that are variants of concern, and then the relationship with the health system, diagnostics, therapeutics, and vaccines, that this is not only about vaccines, but is also about the other approaches and products that are necessary for the full response to the pandemic. And then we all need an integrated decision-making and public health action, because any one of these elements influences the way that we use the other interventions. Next slide, please. So the framework, we really think there are some critical questions, some key data that are needed, decisions required? Is the variant, in order to do a rapid risk assessment and resulting recommendations and a research agenda? So is the variant more virulent or transmissible? Do we need to adapt the public health measures and social measures? Do we need to change vaccine policy or adapt vaccine composition? Is there an impact on therapeutics or the testing strategy? What is the impact on the health system? Is there something that can be done beyond these tools, therapeutics, diagnostics, and vaccines to mitigate that impact? What are the implications for equity? And I will come to that at the end. And what research is needed? So making a distinction between variants and perhaps a word of scariance. Next slide. So this sequence of action, vaccine research, and appraisal of the evidence, the impact on vaccine composition, synthesis of that evidence and decision-making, and finally a public health decision to focus on these priority interventions. Next slide. We do think it's very important to build on existing networks and processes. For the strain and disease surveillance, already pointed out that the distribution of strain testing around the world is very inequitable, and yet we have reference laboratory systems, influenza laboratory systems that can be leveraged more, and other laboratory networks that can be built upon. A coordinated research effort, which could certainly leverage and center on the research and development blueprint around assays in particular, clinical trials and animal models. And then looking carefully at the observational data that is coming out, because this is where much of the data is going to come from, is those observational vaccine effectiveness studies and impact evaluations that are undertaken in places where variants are dominant and circulating. Clearly, the regulatory pathway on WHO, either emergency use listing or pre-qualification, and that critical link with the animal sector, One Health partners, and partners and collaborators around the world. Next slide, please. So I just want to also point to the GISRIS influenza network, which has been really the foundation of so much around the world of the foundation of surveillance for SARS-CoV-2 and can be leveraged even further. Next slide. With respect to the regulatory guidance to evaluate the vaccines for the variants, much of this has been produced already. A rapid development of guidance on evaluation of changes if needed to SARS-CoV-2 vaccines with the US FDA, the EMA, Access Consortium have published guidance. WHO is publishing guidance for PQ and EUL assessments as well. And it's really, the key features of the guidance are shared during that development process in a vaccine cluster and with the WHO R&D blueprint meeting. So there is very high alignment between the regulators on the key features. And I think very strong recognition that the guidance needs to be a living guidance that will have to be modified if needed as the knowledge on the variants increases. Next slide, please. Regulatory approaches to evaluate a modified vaccine really do need this strong alignment on the assumptions that a modified vaccine would be developed by the same manufacturer and same manufacturing process as an existing vaccine, and that neutralization antibodies are important to protection, notwithstanding that we don't yet have a clear correlate of protection. So this feature of non-inferiority of the neutralizing antibody response of the modified vaccine compared to the original vaccine, testing of the primary series of vaccine, as well as the effective booster doses, if those are needed. The clinical efficacy would not be a requirement of a regulatory approach, and a large safety database would also not be a requirement, given that a safety database on the originating product. Guidance for multivalent vaccines as well as monovalent vaccines through Access and EMA being provided. Next slide. On the non-clinical testing, US FDA, EMA, Access, and WHO are all coming out with their assessments of what is needed. These immunization challenge experiments are certainly encouraged. Additional repeat dose toxicity studies are likely not warranted. So you can see across each of these entities the degree to which there is specificity around exactly what is needed, with WHO considering it useful if the prototype vaccine has clinical VE in the 50 to 60% range or greater, and the absence of toxicity data would need to be justified. So I think there is quite a bit of alignment across regulators on how to approach this. Next slide, please.
Doctor, if you could go to your conclusion.
Yes, I'll just go to the last slide then. And what I want to point out in the last slide is the key messages. A globally coordinated response is essential for identifying the variants of concern, their impact on vaccines, any modification to the vaccine composition, and especially on vaccine access and allocation, which remains highly inequitable, although changing quite a bit now in these recent weeks and early months. Enhanced surveillance and strain characterization and a regulatory alignment to assess the modifications to the composition have largely been achieved, but further regulatory guidance is needed for vaccine candidates that are in phase 3 or earlier stages of development. And then finally is the careful policy development and messaging, which is going to be really essential on variants, so as to optimize the vaccine impact and include the support for public confidence in the response. We think that there is a high risk here of the public having misinformation or misunderstanding about the utility of existing vaccines and the need for an adaptation for optimization. So we think this is a really critical component. Thank you.
Thank you very much. So I guess you can stay with us. So you were supposed to leave at 2:30. If you could stay a bit longer, we will try to organize the debates with the following organizations. So first the coordinators, then I opened the catch the eye, so don't hesitate to raise your hand in the room or electronically. I will give the floor to the coordinators. If you have a specific questions for the WHO, then please focus, and then we will give you the floor, Dr. O'Brien, first to have your answers to the coordinators' questions, and then back to the catch the eye. So we start, and please stick to 1 minute and 30 seconds for coordinators or representatives, otherwise we won't make it. Peter Liese to start with for the EPP.
Thank you, Chair, and thank you to our speakers. These are really variants of concern. That's why that's the name. So we have to not exaggerate, but also we have to be careful. My first question is it a coincidence that these variants come from areas where there were also a lot of infections? So many cases means many variants. Is that true, or is it only coincidence? So it shows that COVID-19 is not over, and people are tired with the measures, but the virus get a boost. So we need to be careful, and we need to speed up vaccination however we can. My two concrete questions here. Is it an idea to test everybody first before we vaccinate? Because we have studies out that when people went through the disease, even without symptoms, that they can have the same level of protection as those that are vaccinated. So shouldn't we spare the scare vaccine for people that didn't go through the disease? And what can we do really to use the vaccine more efficiently? For example, the 7th doses from BioNTech Pfizer. And unfortunately, we in the European Union have also now to speak about the export ban, because that's what other countries unfortunately do. Last point, for the long term, EPP is ready to support the Delegated Act. And could the representative of EMA explain a bit better what will be the changes in EMA when we adopt it? And in the long term, we need more cooperation. That's why my pledge to WHO is, if you could have a strong word with the US and the United Kingdom, we need more cooperation, but they do the opposite. They have UK first and America first policy. Thank you.
Thank you, Peter. Jutta Guttelen for S&D.
Thank you, Chair, and thank you to our panelists for very important intervention here today. I would like to start by something that you touched upon, all of you, but I would like to have a little deeper answer, and that's the potential of the vaccine that have already been approved in Europe to be adopted in this to protect against the variants. Looking at the design of the vaccine, do you think that there would be a large difference in the potential to change the composition of the individual vaccine to protect against new variants? I would also like you to include the one Johnson & Johnson vaccine candidate here as well, as it differs a bit from the others. Another very obvious reason we are here today is that not seeing the development that we would have hoped to see it's due to the persistent shortage of vaccine deliveries. We are in a very unfortunate situation where the industry, such as and especially AstraZeneca, reveals one shortcoming after another and fails to deliver on its agreed commitments. This is not acceptable and gravely disrupts the member states' vaccination campaigns. As the countries receive less vaccine doses than expected, the risk of export restrictions increase, as we have seen the last days, where with less vaccine than be expected to be delivered, governments must take action and ensure that they protect the health of the citizens. And of course, that's go to the EU as well. And it's natural to consider export restrictions as a last resort. But having said that, of course, nobody wants it. So I would like to ask Dr. O'Brien from the WHO, what's your view on this situation from a global perspective? What the World Health Organization, what are you doing to protect and make sure that we prevent escalation of this very grave situation?
Thank you, Jutta. Thank you. We move to Niels Torvalds for Renew.
Thank you, Pascal, and thank you for the three persons in the panel, because that was very interesting. And my takes on what they said could probably be boiled down in 5 comments. We can expect new strains of the COVID-19 for the next future because there is a mathematical relation. The more infections we have, the more variants we will have. Meaning that we are going to, that's number 3, meaning we are going to live together with different COVID-19 strains for the next future, let's say next 5-10 years. The slide number 9 in ECD's presentation, I would like to know the reasons for some of the member states not reaching up to the level in monitoring, because that's of course bad. And then number 5, we are living an overly clean life in Europe, and that might lead to us being more perceptible for new infections. There is an old rule for children: give them a little mud to eat and they stay safer in the long run. And that's probably when we see the difference in how the virus is spreading in different parts of the world. The overly clean Europeans or the overly clean Americans are hit worse, and probably for good reasons. Thank you.
Thank you. For ID, we move to Luisa Reggimenti.
Grazie Presidente. I virus evolvono, cambiano e cambieranno ancora, rendendo così vani, senza un'adeguata e tempestiva identificazione dei ceppi circolanti, i vaccini. È essenziale che le agenzie analizzino i campioni sequenziati e in tal senso vorrei chiedere come EMA ed ECDC intendono procedere a tale analisi. Inoltre vorrei chiedere se sono da valutare anche altre strategie terapeutiche non vaccinali. Inoltre, come sappiamo, diversi Stati hanno sospeso la somministrazione del vaccino AstraZeneca a seguito di eventi avversi di tipo tromboembolico che potrebbero derivare anche da una inappropriata valutazione e somministrazione del dosaggio. Vorrei sapere come sono stati valutati i dati clinici per determinare la dose minima efficace e se questa è stata sufficientemente tarata su tutti i tipi di soggetti sottoposti a vaccinazione, fra cui i potenzialmente allergici, bambini e persone già venute in contatto con il virus, e chi effettua i controlli di qualità e quantità del vaccino prodotto in Belgio, Stati Uniti e Regno Unito, poi preparato in dosi in Italia e in Germania. Inoltre vorrei conoscere la posizione delle agenzie e dell'OMS circa l'opportunità di effettuare test sierologici sistematici precedenti al vaccino. Grazie.
Thank you. We move to the Greens and TMS.
Merci, Monsieur le Président. Thank you for the presentation. As my colleagues already mentioned, the issues of variants is both linked to scientific issues, but also raises a lot of concerns regarding the question of access to the vaccines at the global level. First, regarding scientific data, I would like to ask Dr. Marco Cavalieri from the EMA, when will we have an update on the data regarding the capacity of the vaccines to provide sterile immunization? As new variants are spreading faster, this information is quite important to know. And in the light now of the new situation, if I understand well, the EMA is now asking at earlier stages new applicants to investigate the aspect of protecting against variants and on sterile immunization. Secondly, regarding the process of market authorization, can you provide us more details on how the potential booster shots which would be produced to make the already authorized vaccine efficient against the new variants will be granted marketing authorization? Will the EMA ask for the same set of data as for the rest of the vaccines? I would also, it would also be very important that even for these altered vaccines, maximum of safety is ensured, which can only happen if the necessary data are available. Also, will it be possible, if you got the Moderna vaccine, for example, to get a booster shot from another vaccine? Thirdly, on the issues of access to the vaccine, I would like to address my question to the WHO. It is clear now that due to vaccine nationalism, COVAX is not sufficient to ensure timely access to the vaccines for the global population. The EU is playing a major role in this situation, hiding behind charity-oriented solutions instead of solidarity. So what is the third way in the negotiations? That is another question I would like to know. Okay, thank you very much.
Thank you. Coach Kingsley for ECR.
Dziękuję Panie Przewodniczący. Pierwsze pytanie do WHO, drugie, jeżeli zdążę, do EMA i CDC. Jestem świadoma, że grupy badawcze przeprowadziły sekwencjonowanie genomu wirusa COVID-19 i udostępniają te sekwencje w publicznych bazach danych, w tym w zakresie inicjatywy GSET. Z zadowoleniem przyjmuję oświadczenie Światowej Organizacji Zdrowia, która inicjatywę GSET nazwała prawdziwym przełomem obecnej pandemii. Ta globalna współpraca pozwala naukowcom lepiej śledzić zmiany wirusa. WHO zaleca, aby wszystkie kraje zwiększyły sekwencjonowanie wirusa COVID-19 tam, gdzie możliwe i udostępniały dane, aby pomóc sobie nawzajem w monitorowaniu ewoluującej pandemii i reagowaniu na nią. W jaki sposób WHO zamierza wspierać naukowców i promować usuwanie barier utrudniających efektywne udostępnianie danych na największych platformach genomu SARS-CoV-2, chroniąc jednocześnie prawa dostawców tych danych, oraz czy istnieją dodatkowe rekomendacje, jakie planuje wprowadzić WHO, jeśli chodzi o monitorowanie i zrozumienie skuteczności nowo dopuszczonych szczepionek w kontekście pojawiania się nowych wariantów wirusa odpowiadających za wyższy wskaźnik replikacji, zwiększoną zdolność przenoszenia, zjadliwość patogenu, wyższą śmiertelność i jaką wartość dodaną może odegrać w tym pogłębiona współpraca bioinformatyczna w ramach GSET. I bardzo krótko, EMA i CDC, do przedstawicieli mam pytanie, czy będą rozważane dodatkowe oceny i informacje ukazujące skuteczność szczepionek na wypadek realnego prawdopodobieństwa sytuacji, w których odsetek przypadków SARS-CoV-2 spowodowany przez nowe szczepy 1.1.7, 1.5.1 i P1 będzie wzrastał i
Sorry to interrupt.
jakakolwiek poszerzona sprawozdawczość. Dziękuję.
We move to Silvia Modig for the left.
Kiitos Pascal, kiitos arvoisa puheenjohtaja ja kiitos kaikille asiantuntijoille teidän esityksistänne. Todellakin tämä päivitetty tieto siitä, että miten nyt jo Euroopassa hyväksytyt rokotteet, miten ne reagoivat näihin variantteihin. Se päivitetty tieto on tietysti äärimmäisen tärkeää, jotta jäsenmaat pääsee suunnittelemaan seuraavaa vaihetta ja tämä sekvensoinnin, että vain niin harvassa maassa sekvensointia tehdään riittävästi ja riittävällä tasolla on erittäin huolestuttavaa ja on hyvin perusteltua, että sen kuntoon saattamiseen annetaan yhteistä tukea. Mutta minulla on kaksi aihekokonaisuutta. Kun katsoo tätä listaa varianteista, joita pitää seurata, on aivan selvää, että strategian variantteja vastaan pitää myös olla globaali. Ja sen takia pääsen kysymykseen, joka nyt paljon on alkanut keskusteluttamaan, eli rokotetodistus, josta odotamme esitystä. Kaikille teille kolmelle, mitkä on ne lääketieteellisestä näkökulmasta välttämättömät asiat, joita meidän on kerättävä, joista meidän on oltava tieto? Tarkoitan sitä, että missä kukin on rokotettu, milloin, millä rokotteella, jotta sitten varianttien suhteen tiedämme, että millaisella modifioidun rokotteella tai seuraavalla rokotteella asiaan voidaan variantin suhteen reagoida. Eli mitkä on se lääketieteellinen näkökulma siihen rokotekorttiin ja mitä siitä lääketieteellisestä näkökulmasta on välttämätöntä olla, jos siis on. Toinen kysymys liittyy tähän globaaliin vastuuseen, koska niin kauan kuin pandemia ei ole saatu hallintaan, näitä variantteja syntyy yhä uusia ja tilanne pysyy edelleen erittäin vaikeana. WHOlta haluaisin tiedustella sitä, että mikä on käsityksenne COVAXin toiminnasta, miten näette, että tämä tutkimus ja kehitys, näiden varianttien tutkimus ja siitä sitten juontava rokotteiden kehitys, miten siihen saadaan mukaan myös se globaali vastuu, koska kyse ei nyt ole ainoastaan siitä,
Thank you, Silvia.
Thank you, Pascal.
Thank you. So we move directly to the answers from the WHO, Dr. O'Brien, then back to the Catch the Eye, and back to the other panelists. Dr. O'Brien, the floor is yours.
Thank you so much. Let me try and tackle as many of these questions as I can. On the first issue of, is there a need to test individuals before vaccination? WHO has been really clear about this. In fact, I just came from the SAGE meeting where this was reaffirmed again, that this is not a recommendation. Having any need or requirement for testing individuals before vaccination is simply putting a new barrier up for individuals to be vaccinated. Even if somebody has had COVID disease in the weeks or months preceding their possible vaccination, not everybody who has been infected will necessarily have durable immunity after in the period following. So we think that it continues to be an important policy position that testing before vaccination is simply putting up a new barrier for people to get vaccinated, and the advice is to proceed as quickly as possible with vaccination of the highest risk groups to begin with, and then working their way down. On the question of how to use vaccine more efficiently, one of the issues is, especially in this constrained supply situation, and for some of the vaccines, the evidence on increasing the interval between the doses of vaccine, and a growing body of evidence around the opportunities for stretching the supply presently by distributing vaccines as first doses, especially in countries that are just beginning the vaccination program, and extending the interval between the doses with really much growing data on the use of this strategy with the AstraZeneca vaccine and some data on the Pfizer vaccine coming through. So one approach is clearly to use the vaccines that do have efficacy following a first dose, and again, a growing body of evidence around the degree of efficacy even following a first dose for a period of up to 12 weeks in the case of the AstraZeneca product. The question also came up on mix and match, what we would call mix and match. Can you use one vaccine and then have a different vaccine as your second dose? And there's no data on this idea yet. There are a limited number of studies that have been initiated to look at mixing and matching of vaccines. There are hypothetical reasons why it should work, but we really need the evidence. So again, the recommendation is that to get the same vaccine as your second dose wherever that is possible. And then I do want to address the issue on COVAX. COVAX is in a rapid rollout period right now, where the vaccines that are available in COVAX for supply, I think as everybody knows, the Serum Institute of India is the one supplier around the world that is dedicated to supplying the COVAX facility along with India. And the doses that are coming out of that facility, we are certainly hearing about, aware of other deals that are being done with SII. And I think we just have to recognize that none of us want to be in a position where those doses are essentially going to other economies and being taken from the low income and low middle income AMC countries. And so I think everybody is committed to that, the way the deals were arranged was for that supply to go through to India itself and then to the AMC countries. So those doses are moving out rapidly, with over 30 countries now with shipments being deployed and tens of millions of doses that have rolled out in a 2-week period, and we will be moving to over 100 million doses in the short near future, assuming that the supply that is expected is preserved for those AMC countries. Another question is just around COVAX and the timely access. And COVAX has been really clear that the initial goal was to protect the most at risk for severe disease and death and to protect the health system. But COVAX's goal is to do whatever is necessary to support countries to control and end the pandemic. That is really only dependent on the resources that are available in terms of doses and dollars to assure that there is that supply to provide and support countries. So the next enterprise is really to advance the means by which COVAX has access to doses, both through dose sharing, donations, financial means, both through donors, and of course Europe has been an extraordinary supporter of COVAX. And we're seeing now the fruits of that investment with rapid scaling of doses going into countries. And there is more that needs to be done. I think we all recognize that, both in terms of the variant issue and the coverage in those countries. On the issue around...
Sorry, Kathy, that will be your last minute. So please...
I'll just address the vaccine passport, the electronic vaccine certificate issue. We strongly support the use of electronic vaccine certificates as a means for individuals to have a record and of programs to facilitate their programs. As I think you know, there is no recommendation from the International Health Regulation, International IHR, for using vaccine certificates for the purpose of international travel. And there are, at this time, not the conditions in place that would support that. As you indicated, a lack of evidence on the magnitude with which vaccines protect against transmission and insufficient access to supply to allow that free movement of people, or the diversion of doses that should be given to highest risk individuals, which would then be given to people who are intending to travel internationally if that were to take place. So I'll end there on that point.
Thank you, Dr. Brian. Thank you for staying with us a bit longer. So as you are all aware, we are running really way late. We should be moving to the next topic right now. So, of course, we will have the catch the eye. So please stick to the 1 minute. I will have to be very strict. Let's start with the EPP and Christian Bouzoy.
Thank you very much, dear President. I will be very brief. First of all, I would like to thank ECDC, EMA, and WHO for the presentations and for the very good work that they are doing. Of course, during what we are making now, we will reinforce the role of some of the institutions, and I'm very much involved in reinforcing and strengthening the role of EMA. There are current uncertainties, and yes, the current vaccines have efficacy and are proven to be effective, but not fully or very high for the 3 existing mutations variants. There is a lack of data and monitoring on the 3 variants, and the other reality is still that we cannot foresee the evolution of variants or the speed with which this virus mutates. So the most important question now for ECDC and EMA would be the speed, the collection of data. What would be the speed of the collection of data on efficacy and monitoring the variants or speed of mutations? Thank you so much.
Thank you. Sarah Cerdas for SND.
Thank you, Chair. I'll try to be brief. I have a question for ECDC and EMA. I would like to thank all the speakers for bringing such topic up to the discussion here. For ECDC, how that map that you showed, that some other colleague already referred, is a bit concerning on genomic sequencing. So how are you supporting member states to reach the necessary data in order to have the genomic sequencing and monitoring of all the mutations that are going on at their parts? And for EMA, my question has to do with the vaccine and how are you working and collecting new variants, and how are they influencing the vaccine's efficiency? Pfizer told us here at Parliament that in 100 days they could have a new vaccine for a new strain, new mutated strain. This is for an RNA messenger vaccine. What is the timeline for the EMA approval in case this happens?
Thank you very much. Véronique Riel-Lenoir for Renew.
Merci beaucoup, Monsieur le Président. Je partage les questions de Sarah Cerdas, donc je vais focaliser mon propos sur ECDC. Nous assistons actuellement à une augmentation importante des taux d'infection, avec dans certains pays des problématiques de saturation des services de réanimation. Il a été clairement dit déjà que le nombre de taux d'infection détermine mathématiquement le nombre de mutations vers de nouveaux variants et que nous allons forcément être confrontés dans les mois et les années qui viennent à de très nombreux variants. Jusqu'ici, l'attribution des vaccins a été faite en Union européenne au prorata des populations et il ne faut pas croire la désinformation qui consiste à laisser entendre que certains pays auraient mieux tiré leur épingle du jeu, c'est faux. En revanche, si le nombre de variants augmente et que l'hétérogénéité de l'infection virale augmente, alors est-ce que nous ne serons pas amenés à prendre des dispositions différentes en fonction de l'évolution de l'infection et donc d'un pays à l'autre? Merci beaucoup.
We move to the EPP and Dolores Montserrat.
Hello, do you hear me? Yes. AstraZeneca, it's not delivering the committed doses of its vaccine, and now there is also an issue with collateral effects after one death and other health problems of the people vaccinated. So 6 countries have suspended the administration of its vaccine, and people is getting scared. What can EMA say to secure us? That's all.
Thank you. For SND, Madam Schadelmoser.
Thank you very much. Along the lines of the last question here, I would like to know from EMA, what is the process from here when we hear and learn about potential side effects from the AstraZeneca vaccine? What are EMA doing to check this out? What is the process that could be important to know? And I would also like to know how do EMA have full access to data, for instance, from UK on efficacy, variants, and side effects, etc. So, I mean, of course, we have it from EU, but do we also have full access to data from out of EU? Thanks.
Thank you. We move to Renew and Nicola Stefanota.
Merci, Monsieur le Président. We know that reaching the target of 5% of genome sequencing of positive tests in every member state will take time, even with the funds from the HERA incubator, which are estimated at 75 million. My question is, what support is now operational for the countries that don't have the necessary capacities, and if the ECDC will work with contracted laboratories to supplement the sequencing capacities in Europe? And what is the realistic time frame for the 5% goal to be reached and the progress recorded in the capacity in the last couple of months? Merci.
Merci. For ID, Joël Mélin.
Oui, merci Monsieur le Président. La connexion était difficile. Oui, rapidement. Donc, merci beaucoup aux trois intervenants qui ont posé une problématique qui est manifestement extrêmement large et qui dépasse en programme tout ce qui a toujours été fait dans le monde, où à chaque fois que des expérimentations ou des relevés, des retours d'expérience ont été donnés, c'était sur des épidémies ciblées, limitées. Puisque nous parlons des variants, il y a quand même une question que personne ne pose et que je vais oser poser une bonne fois pour toutes parce que ça commence à circuler. Et particulièrement au regard de l'OMS et de la position du rapporteur de la commission, de la commission qui s'est rendue à Wuhan pour discuter avec les Chinois et voir un petit peu l'origine de cette épidémie. Tant qu'on n'aura pas exactement l'origine et qu'on ne saura pas si, ce qui n'est ni prouvé, mais non plus ni infirmé. Il ne s'agit pas d'une fuite de laboratoire et qu'on ne saura pas si le virus initial a, pour une raison X ou Y, été artificialisé, a subi une modification de la main de l'homme, nous ne pourrons pas anticiper les variants. Je demande à tout le monde de bien vouloir s'en occuper.
Pour les Verts, Michel Rivasi.
Voilà. Merci, Monsieur le Président. Alors, rapidement, si on veut vraiment lutter contre cette épidémie, il faut avoir une bonne cartographie de la propagation des variants. Et je suis assez surprise que la cartographie de l'ECDC ne repose que sur 9 États membres qui ont les moyens de faire un séquençage. Donc là, il y a urgence. Deuxième chose sur l'ECDC, je voulais savoir la validité des tests PCR. Est-ce qu'ils ont une recommandation sur les seuils d'amplification concernant les PCR? Parce que souvent, il y a des faux positifs parce qu'on amplifie énormément les restes de coronavirus. Au niveau de l'EMA, il faut absolument que l'EMA réponde aux effets secondaires d'AstraZeneca. Il y a énormément de pays qui suspendent ce vaccin. Qu'en est-il? Et troisième chose, il faut absolument qu'on ait des données sur l'efficacité des vaccins en fonction des variants pour adapter la vaccination en fonction des variants qui se développent. Et
merci beaucoup. Merci.
Comment se favorise l'apparition des...
Merci. For ECR, Alexander Vondra. Okay, so Madame Zaliuska for ECR.
Hello. Okay. Dzień dobry, witam bardzo serdecznie. Ja kilka pytań, takich organizacyjnych pytań. Po pierwsze, dziękuję panu przewodniczącemu, że zaczął czuwać nad tym, co robi komisja i nasze agencje w sprawie szczepionek i że mamy zespół, który to monitoruje. Natomiast niepokoi mnie sformułowanie przewodniczącego, że jest to jakąś tajemnicą. Dobrze by było, gdyby pan przewodniczący powiedział nam, jakie są tego powody i w jaki sposób będzie nas informował o tychże właśnie rozmowach. Jednocześnie padły tutaj dwie ważne informacje mówiące o tym, że jutro być może będziemy głosować nad aktem delegowanym o procedurze przyspieszenia dopuszczenia szczepionek. No, panie przewodniczący, proszę zwrócić uwagę, że my rok już zajmujemy się pandemią, a dawanie nam dosłownie kilku godzin, żeby się zapoznać z ewentualnym aktem delegowania jest po prostu nieporozumieniem.
Merci.
Jednocześnie
mówimy
też...
Thank you. Sorry, I have to be the timekeeper. We move to the left, Madam Konieczna.
Thank you, Mr. Chairman. So my question will be about the variants. It's quite clear to me that for many justifiable reason we cannot avoid the spread of mutation that have arisen in Europe, including in Great Britain. However, according to your presentation, variants from third countries are also spreading here. How is it possible that the South Africa variant has already spread massively here? Is there a risk of this, for example, the case of Brazilian variants? It seems that the current rules are not enough and Europeans still travel a lot of outside here. Are these journeys safe? Do you have any statistics on what in the reason of these trips? Are those trips a reaction of or business? Are any data which tell us what was the reason of the journey of the person who got ill in third country and took the disease back to the EU? Thank you very much.
Thank you. So we move back to the panelists, starting with the EMA and Dr. Mario Cavarelli for 5 minutes.
Can you hear me now?
Yes, go ahead.
Yes. Thank you very much. And thanks for all the very good questions. I will start by covering some of the questions on the process for the variant vaccine approval. Indeed, what happens here is that manufacturers don't have to resubmit an entire file from scratch, but essentially it will be approved as a kind of a variation on the dossier that was leading to the initial approval of the vaccine. And this will save a lot of time and will make things more straightforward and flexible in terms of what will be submitted and the time frame of the process for approval. So that is an important point that is essentially building on what is already done every year for the influenza vaccines, where they get an update with respect to the strains that are incorporated into this vaccine. So, and then I think an important element of flexibility is that it would be possible to have different variant vaccine included in the same marketing authorization, which also is a very important element that would allow us to be faster and more agile. In terms of, there was a related question around the booster dose. Indeed, we are expecting that marketing authorization holders will conduct studies with the variant vaccine as a booster for those that already received the primary series of, so the vaccine that was in the original, with the original strain, and that is something that we will be looking at. Of course, we are very much open also to discuss the possibility of having a more universal booster strategy, which means using a booster dose after subjects have received maybe other vaccines or have been exposed naturally to the virus. So this is something that we will be discussing more. And there was also an explicit question about the timelines for such an approval, and I think this will be done in a matter of weeks or maybe even shorter than that, depending on the dossier and the scientific assessment of the data. There were some questions on AstraZeneca, starting from the supply, and indeed we are working in order to speed up the approval of additional manufacturing sites this month. that could really boost the availability of the vaccine across the European Union. And also there were some questions around the minimal dose for the AstraZeneca vaccine. Indeed, the study looked at different doses, and the dose was selected based on the experience with other pathogens, but also based on animal models and the immune response in humans, both younger adults and in the elderly. So there are quite a number of information supporting the decision to go with that specific dose that has been approved. With respect to the safety, indeed, we are receiving the data from the UK. They are submitted to Intravigilance. And as we already stated last week, we are going through a rapid review of all the evidence around thromboembolic events with this vaccine in order to make sure what is the benefit risk for the use of the vaccine. As I stated already, we don't think that so far the evidence that we collected is showing that we have really an emerging risk affecting the benefit risk, and still the benefit risk of the AstraZeneca vaccine is considered positive, and we would not see any problem in continuing with the vaccination campaign using this vaccine. At the same time, of course, we are scrutinizing all the data, particularly the fatal cases that have been reported in Intravigilance, in order to try to understand if there are any specific cluster of cases around a certain type of pathologies or background status, medical status of the subjects, in order to refine then the benefit risk of this vaccine. Other question that was raised was about sterilizing immunity. We will have more data coming up from the clinical trials via understanding those that have seroconverted even if there was no really symptomatic disease with COVID-19, and that will be a kind of a proxy for what we can say about prevention of infection. At the same time, I have to say that the real-world evidence data that are emerging from various parts of the world, and very recently data from Israel were presented, that really show that, like the BioNTech Pfizer vaccine, is able to induce a good level of protection, not only from symptomatic COVID, but also from infection. And we are looking forward getting more data, not only indeed from clinical trials, but also from real-world evidence that would tell us exactly to what extent these vaccines are able to prevent infection. And not forgetting that in terms of transmission, what really matters is really turning down the amount of viruses that is replicating in the upper respiratory tract as a good way of defining when the vaccine will be able to block transmission. I think there were also a question about people that have already been infected and whether they should be vaccinated. I think that the colleague from WHO already explained that there would be merit in receiving a vaccination also in this group, while we fully understand and recognize they might not be the priority group for vaccination at this stage, and also considering the short of supply. But at the same time, there is also a debate ongoing whether they would require 2 full doses or a single dose like for the messenger RNA vaccine, and this is something that we are debating based on the current evidence that will show that maybe a single dose could be sufficient in these people who were already encountering the virus as natural infection. However, not forgetting that the level of immunity in subjects that have been naturally exposed to the virus may be extremely variable, and therefore might be difficult to be definitive on this aspect. I think we're also been monitoring very closely the data on the emerging variants, and to see whether we know, not only from real-world evidence and laboratory data, but from any other sources, what we can say about the potential implication on the protection from this vaccine, and we will continue so in the coming months. I think I will stop here.
Thank you very much. And we conclude with Dr. Bruno Ciancio for ECDC.
Please, Mr. Ciancio, press the speak button.
Yes, can you hear me? Yes.
Yes, please.
So I cluster the questions by topic, and I think the first topic is about what CDC is doing to support countries that are dealing with shortages when it comes to sequencing of the variants. Now, what we are currently doing is to actually sequence on behalf of member states. So we have a significant budget to perform sequencing for the member states that do not have this capacity. we are starting prioritizing member states with very limited or no capacity. And in the next months, we will be able also to support other member states that are not yet, that are still able to sequence, but are not yet to the required level of sequencing. As I said, we scale up this to a great extent thanks to additional fund that the Commission will make available to the level that is needed actually to achieve this threshold of sequencing for all member states. And a lot depends also on the ability of member states to actually provide samples for sequencing. Therefore, we are also thinking of supporting the collection of specimens in member states and the shipment of these specimens to the laboratories that will perform this. The laboratories that will perform this sequencing are commercial laboratories that are independent from the public health laboratories in order to avoid competing with the same resources that are in the member states. As you can see, this approach is not sustainable in the longer term. It's very expensive, and we need to invest in member states' abilities to perform this type of advanced diagnostic. And someone asked about what this will be. So this will be an important program in which all member states will be involved, which will entail training, which will entail acquisition of new equipment and devices, and support the transition from the old technologies used to the new technologies, which requires also longer-term investments in training and staff. Now, there was some question on the timeliness for the vaccine effectiveness data. ECDC, as you know, will be supporting this type of studies in the field. However, in order to obtain quick vaccine effectiveness results, we need quite a significant proportion of the population to be vaccinated. And therefore, and then we will need to also separate out the population by type of vaccine that they've received, by age, etc., in order to give reliable estimates of vaccine effectiveness by vaccine, by variant, and by age. So this, unfortunately, will take a few more months before we are able to provide reliable results on vaccine effectiveness from the EU. There were questions about the PCR test and if we have a threshold. WHO has defined clear guidelines for the interpretation of PCR results, and I think those should be followed by the laboratories. I think in order to avoid confusion, ECDC also defined when a person can be considered not infectious after the first PCR test positive. And a person with mild symptoms can be, based on studies and evidence on the antibody response to the first infection, one person can be considered not infectious after 10 days from the first positive test. There were some questions on how is it possible that the African spread so fast. Well, of course, people movements and travels do play a role to the spread of new variants, and this is the reason why in our risk assessments in end of January and February, ECDC advised to avoid as much as possible the non-essential travels. However, at the same time, once a variant has been established in a population, it will rapidly grow unless it is controlled by the public health measures in place. And so travel do play much less role in such a situation. There were indications of changing the vaccine distribution by population based on the presence of the variants? No. I mean, we need to protect the vulnerable in all populations, regardless of which variant is circulating. So the prioritization should still go to those that are at highest risk of dying. We cannot change the vaccination strategy. The only change is the timeliness. We need to vaccinate faster, faster, and faster in order to protect the highest number of at risk as soon as possible.
Thank you. Sorry, I really have to interrupt you, and we are going to have other opportunities to have exchanges with the ECDC. Sorry for that. I hope you will understand that we are running almost 30 minutes late, and we do have to move to the next topic. So thank you for that. A lot of questions. It's obvious that it is a very hot topic, and we need now to move to the next topic, which is actually highly related. And thank you again for our panelists. So we move to the agenda item number 5, which is the communication from the Commission to the Parliament Council about HERA incubators. So I will give the floor first to the Deputy Director General Pierre Deslot from the DG Santé to make a presentation that will not duplicate what we have already heard so far, and then to the coordinators and to the members. The floor is yours.
Merci, Monsieur le Président. Don't be afraid, I will be short, and I know I don't need to repeat everything which has been said before, so I will try to focus on a certain number of points. Thank you very much for the invitation. As you mentioned, we have this communication is creating the so-called HERA incubator. What's the objective? As we have said, is basically to be ready to fight the new variants of concerns and to make sure that we get the vaccines needed for our population. So that's the objective. And what we don't want at this stage not to create a new authority, but simply to create a partnership between all stakeholders, all parties, to make sure that we are ready in time. And that could be also preparation for HERA. Second message, what do we want to do? We want to look at that problem from a holistic approach, so from end to end, starting with the sequencing, detecting the variants of concerns until the production. So not working on this in isolation, but trying to connect the dots, because we believe it's important that we have this global vision. Now, if I look at the different measures that we propose, first of all, it has already been discussed quite at length, is a question of detecting the new variants of concerns. Actually, now we propose to put on the table 200 million, so more than the 75 million which have been foreseen in the communication. So we want to increase the amount of budget which is allocated for this task. And if you look at the split of the money, again, not a clear split, but we would be looking at 3 aspects: sequencing, improving the sequencing like it has been discussed in the previous panel. Second element, which we believe is important, we need also to look at test PCR and to see whether we can develop or purchase test PCR which are able to detect the variants, because we believe it's a very important element. And last aspect is a question of wastewater monitoring, which could be also a very good tool actually to detect possible variants and possible crises. So we want also to invest some money in wastewater monitoring. Second element, research and development, which is of course important when you have detected the variant. Research and development, we want to monopolize 150 million euros out of Horizon 2020, still the current budget, and out of Horizon Europe on basically how to do research and development to better address what we do with variants of concerns. So this money will be monopolized, will be invested as soon as possible, meaning already now for a certain extent. Next element, which also has not been mentioned so far, but which also is something which we believe is important, we have created a clinical trial network in Europe with close to 200 partners in Europe. And we believe this is extremely important because so far it's not the case, and it would help to facilitate, the testing in Europe and also the link with the work which is being done by EMA, because that's, it's easier, of course, to have connection when the testing is made in Europe. This is a reality. It has started, and so we're investing money in this because we believe it's important. One aspect also, we want to use this network also for testing children and doing things because children so far have been, children and adolescents have been so far left out but still we believe it's important that we work also on that question at this stage. So the next element, I would say, of the end-to-end process. The next one is, you already mentioned it, Mr. Chairman, is a question of fast-track approval of vaccines, of modified vaccines, which I know is a very important element. EMA has already mentioned the way they want to accompany the process and to make sure actually they are part of the process and get the data as soon as possible to facilitate the process. And I know, don't ask me the question, you are waiting for this delegated act. I know you are ready, and thank you very much for this, for being ready. I hope the Commission will be ready in time. We are doing our best, and I've again transmitted the message to my counterpart at the Parliament to make sure that you are waiting for us. So certainly you are not to be blamed in this. I fully understand the situation in which you are. It's our responsibility and not your responsibility. Last element, of course, and which is a very important one, once we have done, detect variants of concerns, when we have developed, done research and so on, we need, of course, to make sure that we have enough production of vaccine in Europe. And because that's something which will be extremely important, and we need to anticipate this. So, of course, the task force which is being led by Mr. Breton is important in this context because, of course, the more capabilities we have in Europe, the more possibilities we'll have also to produce the new vaccines, I would say. One aspect also which also is an important tool is the APAs, advanced purchase agreement. We have them. So we might need to use the APAs. But to be clear also, and that's part of the communication, one lesson we have learned from the previous APAs is the fact that before finalizing an APA, it's important that we have some kind of guarantee that there will be enough production capabilities from these producers. And again, I'm not, it's just something which we need to work on this because we believe that's something which is very important. So I would stop here on HERA incubator because, again, I don't need to be too long on that. One aspect, of course, HERA incubator could also be a precursor to help us to understand how to shape HERA, which will be, of course, the next phase. But, of course, for HERA, we will have a legislative proposal which will be discussed with you and the Council, of course. I stop here. Thank you very much.
Thank you very much. And apparently we haven't checked enough the capacity of delivering from some laboratories like AstraZeneca when signing. So I will now give the floor to the coordinators or representatives, starting with the EPP and Peter Liese.
Thank you, Chair, and thank you to the Commission. I really welcome especially the point on children, because children are normally not under a big risk with COVID-19, but if they belong to a risk group like Down syndrome or children with cancer, it's really important that we have a vaccine for them. On the delegated act, can you specify a little bit more clear how you can speed up the process without compromising safety? Because Tilly Metz was raising that point. I think we need to be fast and give us assurance that you are still on the safe side. Last point, I think to really address the variants of concern, we need also to vaccinate the world. And while I, as EPP, support that we keep the intellectual property, but we need to cooperate. So how can we strengthen cooperation with countries like India and South Africa, that they also can help to produce the vaccine to really vaccinate the world? Because we are not safe if not everybody is safe.
Thank you. Jutta Gutteland for SND.
Thank you, Chair. And dear Director Delso, thank you for being here. And I would like to start by saying that the S&D Group supports the effort of the Commission to work with the industry and the Member State to increase the capacity of the current vaccine production and try to adjust the vaccine to the new variants as necessary. And I also appreciated what you said about children and the importance of having proper studies there. We also support the Commission's ongoing effort to accelerate the availability of raw materials for the vaccine production, as well as to facilitate agreements between manufacturers across supply chains and production sites to help scaling up the production in the EU. Nationally, additional research and development effort will be crucial as well. Time is always essential in the fight to this virus. We know that well now. I would be interested in hearing more about how quickly, practically speaking, you think that the procedure under the HERA incubator could result in adaptation of vaccines to new strains of virus. Could you also please elaborate a bit on the intellectual property rights and patents fit into the puzzle here? Do you expect that the development of this voluntary decided licensing mechanism for facilitating technology transfer will resolve the possible bottlenecks in production and access to vaccine? Finally, I would also like to ask you for an update on the expected deliveries of the currently authorized vaccines, but also for future vaccine up for market authorization, especially considering development with Johnson & Johnson in the United States. How do you see the process with the ongoing export restrictions? How will that impact the availabilities? Thank you.
Thank you. We move to Niels Torvalds for Renew.
Thank you, Chair. And to speed up the procedure here, 3 short questions or comments. The HERA incubator is meant to speed up the process, help the companies, and then you have something which I found probably coming out more of a dream pipe than of reality. You speak about a voluntary dedicated licensing mechanism. Do you really think that the voluntary dedicated licensing mechanism will work during these circumstances? So far, we haven't actually seen very much evidence.
We lost Niels Torvalds, so I suggest we move to...
Yeah, please, sir, go ahead. We lost the last few seconds of your intervention.
No, I just was about to I need to know what you really think about the voluntary dedicated licensing mechanism, because I think that's crucial. Thank you.
Thank you, Niels. So there is no speaker for ID. We move to the Greens and Michel Rivasi.
Merci Pascal Canfin. Écoutez, moi je salue la démarche de répondre à l'urgence, de faire face à l'impact des variants du virus. Mais par contre, j'apprécie pas du tout la méthode. Parce qu'en fait, vous parlez d'un partenariat public-privé qui associe la Commission et l'industrie et vous éjectez encore une fois le rôle du Parlement européen. Alors, quels seront les engagements et les responsabilités des parties ? Les laboratoires pharmaceutiques recevront-ils cet argent public sans contrepartie? Que va réellement apporter l'industrie dans cette démarche? Qu'a prévu la Commission en termes de gouvernance, de transparence et de propriété des données? Vous avez parlé du nouveau réseau des essais cliniques, Vaxcelerate. Alors, à qui va appartenir ces données? Est-ce qu'elles seront dans le domaine public ou sous la responsabilité des universités et des autorités sanitaires? Alors, je vous dis qu'on a besoin énormément de transparence sur le type de recherche soutenue. Alors, combien d'argent public va être investi? Vous nous parlez de 150 millions d'euros pour la recherche et développement, maintenant 200 millions pour le séquençage. Ça sera mis sous quelles conditions? Et justement, quel sera le rôle du Parlement européen? Et alors, ça commence mal, parce que la semaine passée, la Commission nous envoie un courrier demandant au Parlement d'approuver une procédure de non-objection rapide à la future modification de la législation de l'Union européenne sur les variants. Alors pourquoi commencer à vouloir garantir que le Parlement ne s'en mêle pas? Comment se fait-il que le projet d'acte délégué ne soit pas visible en ligne avant que le Parlement se prononce? Enfin, de telle manière, ça n'entraîne que la défiance et on se pose des questions sur votre fonctionnement. Déjà,
Merci.
vous n'avez toujours pas transmis le contrat de Moderna, de Pfizer. Vous êtes en retard par rapport
Merci
à
Michel.
la problématique.
Merci beaucoup. We move to ECR and Madame Kobzinska.
Dziękuję Panie Przewodniczący. Ja mam krótkie pytanie formalne związane z inkubatorem HERA. Wstępna ocena mapy drogowej HERA została zakończona 24 lutego bieżącego roku. Obecnie Komisja jest w trakcie zbierania napływających zwrotnych informacji. Konsultacje publiczne są przewidziane na ten kwartał. Chciałam zapytać, w jaki sposób inicjatywa inkubatora HERA związana z projektem EU-FAB, rola partnerstwa publiczno-prywatnego, idea Accelerate oraz pozostałe inicjatywy inkubatora nie wyprzedzają rezultatów wyników wstępnej oceny, publicznych konsultacji i odpowiedzi na pytanie, jakie jest stanowisko potencjalnie zaangażowanych podmiotów, a nawet samej Rady, co wyboru poszczególnych wariantów strategicznych proponowanych wobec ustanowienia urzędu HERA, jej struktury i modelu funkcjonalnego przedstawionego w 3 scenariuszach wstępnej oceny mapy drogowej. Dziękuję.
Thank you very much. And before giving the floor to the last coordinator, I'll formally open the Catch the Eye for the next part of this session. Now we move to the left, and Madam Konieczna.
Thank you, Mr. Chair, and thank you, Commission. Do I understand correctly that the purchase of vaccine adapted for new variants will require the conclusion of completely new contracts with same manufacturers? It's not possible to use existing contracts. How long will it take to conclude such a new contract this time? Doesn't it delay delivery? So in the future, will deliveries run concurrently under the old contracts and at the same time under new contracts for vaccines against vaccines? Is the procedure effective at all? What good will old vaccine against variants work for us? What will we do with the old vaccine which are non-effective against the variants? Thank you for your answer and sorry for so many questions, but it's really crucial topics for us. Thank you very much.
Thank you. So for the Catch the Eye, I don't have any speakers for EPP, nor for SND. So I move to Renew and Véronique Trier-Lenoir.
Merci, Monsieur le Président. Merci, Monsieur, d'avoir évoqué la problématique très importante de la recherche clinique et d'avoir répondu à ma question qui était est-ce que le réseau Vaccéléret est opérationnel? Vous nous avez rassurés là-dessus. J'aimerais savoir dans quel pays et au sein de quelles institutions. Vous nous avez également indiqué, et ça me paraît très important, que les essais cliniques seraient menés chez les enfants. Arriverez-vous à vaincre la problématique qui est celle de l'inclusion d'une personne dans un essai clinique piloté par un pays européen dont il n'est pas ressortissant? Est-ce qu'un volontaire français pourra participer à une étude menée en Roumanie? Comme vous le savez, probablement c'est un problème général avec les essais cliniques. Est-ce que HERA va nous permettre d'avancer là-dessus? Merci beaucoup.
Merci. We move to the Greens. Jutta Paulus.
Thank you, Chair. And my question is rather short. Surely you have heard of the RADVAC initiative, which was originating in the US, where a group of scientists has developed a very well down-to-earth sort of vaccine which aims at the mucosa, and it can be administered by a nasal spray. And this vaccine, of course, could be adapted to variants very easily because it's based on introducing peptides into the nose, and you just have to change the peptide according to the new variant. Unfortunately, those scientists are working on a non-profit base. Therefore, we cannot find any potential market authorization holder because the spray could not be patented at the end of the day. So is there any possibility within the HERA incubator to have this nasal spray examined in a proper clinical trial, and which procedures would have to be adopted for this? Thanks.
Thank you. For the left, Mick Wallace.
Thanks very much, President. I'm very disappointed in the clear lack of solidarity with the Global South in the Commission's communication. The communication refers to a new voluntary dedicated licensing mechanism, which would allow technology owners to retain a continual control over their rights while guaranteeing that technology, know-how and data are effectively shared with a wider group of manufacturers. There's a number of problems with this aspect of the proposal. Firstly, the new voluntary licensing mechanism appears intended to only address the EU's manufacturing capacity, not global capacity. Secondly, the Commission's proposal for the EU's own licensing and technology transfer mechanism will put it into competition with existing international mechanisms such as initiatives from the WHO and the UN. Thirdly, there is no sign of civil society oversight in relation to any of the instruments proposed here. Therefore, negotiations will continue behind closed doors. And lastly, advanced purchase agreements. In future, they must include clauses guaranteeing downstream global access and affordability, as well as the transfer of manufacturing know-how that ensure vaccines are a public good. The whole HERA proposal is premised on the basis of closer public-private partnership model, which has promoted vaccine apartheid this time round, and with the likes of Pfizer in Latin America behaving like imperial powers. Thanks, President.
Thank you. For Renew, Frédéric Ries.
Merci beaucoup, Président. Oui, juste une question rapidement. J'entends bien la Commission et tous les orateurs qui se sont succédés ici, notamment lors du point précédent, nous dire à quel point la question de l'identification du variant est essentielle et prioritaire. Identifier, repérer, séquencer, donc pour ensuite mieux contenir. Alors, juste une question à la Commission et au directeur général adjoint. Je note quelque part dans votre communication que vous parlez d'un seuil à atteindre minimum de 5%. De tests séquencés. On a entendu certains de mes collègues dire à quel point c'était difficile dans certains États membres d'y arriver. En revanche, pour d'autres, on est largement au-delà. On a cité le Danemark, je pense déjà, la Belgique aussi. Enfin, la Belgique, ça dépend des semaines. Il y a des semaines où on est très fort et des semaines où on l'est un peu moins. Donc voilà, je voulais savoir ce 5%, il est la force des choses ou bien il est quelque chose qui correspond à des données. Je vous remercie d'avoir annoncé, je ne sais pas si on a un timing, je vais peut-être profiter du fait qu'on n'a pas beaucoup d'orateurs pour le moment, avoir quelques secondes de plus. D'avoir annoncé que vous passiez de 75 millions à 200 millions en matière de soutien, c'est essentiel. Ça nous met là pour une fois à égalité avec les États-Unis, c'est parfait. Et de quelle façon allons-nous travailler avec les Britanniques, dont on connaît, comment vais-je la qualifier, l'expertise historique, logistique en matière de séquençage. Donc est-ce qu'on va travailler avec notamment le consortium britannique de génomique? Merci beaucoup.
Merci. And the last question from non-inscrit, Ivan Sicic.
Thank you, Mr. President. My question is about vaccine efficiency. Some time ago, we had 7 directors from 7 pharmaceutical companies here addressing the committee. Some of them claimed that they have 95% vaccine efficiency, of course, based on their own studies. I would just like to quote Ms. Marcia Angel, who was editor-in-chief of New England Journal of Medicine, probably the best such magazine in the world. I quote, "Conflict of interest and bias exist in virtually every field of medicine, particularly those that rely heavily on drugs and devices. It is simply no longer possible to believe much of the clinical guidelines research that is published." End of quote. So my question is, before approval, was this research of 95% independently confirmed by a study that is not linked to corporate research, or was it not? Thank you.
Thank you. So you have the expected 10 minutes to answer the questions.
Thank you very much, Chairman, and thank you very much, members of this Parliament, to ask a lot of questions, actually, and try to answer to those questions in quite a few times. So I will go through the different questions in the order and not trying necessarily because I believe it's simpler. On the question of children, several of you say it's important, and I agree with you, it's important because we know they are not necessarily too much affected for the moment, but who knows for the future, and we need to anticipate. So we need to be ready. So the participation of children, like you say, is something which I believe is important. On the question of the delegated act, and I'm not talking about the timing, I'm talking about the content, as one of the coordinators said, Peter Lee said, of course, speed should not be to the detriment of safety. it's clear that we need to make sure that when something is being approved, it's safe. And in the previous session, you had a long explanation by EMA explaining to which extent they want to be associated to the development and to make sure actually they are fully informed of the development of the new vaccines, to make sure that when they are faced with an approval process, they already got a lot of information. And that's what we want to do in this context. So the text that you will hopefully not oppose one day, I don't want to be too clear on that, but hopefully you will not oppose to this text, is actually based on what exists for the flu. Now, as you know, every year for the flu there is a new type of vaccine which is being approved, and that's a system that we want to develop for COVID also in the context of the crisis in which we are. Last point which was mentioned, the question of vaccinating the world. Yes, we agree. I don't believe there is a disagreement on this. It's clear as a Commission, as the EU, we need also to work internationally. We need to work with our partners. We need to work with the rest of the world. And we need to make sure actually that they get the vaccines that they need. And COVAX is certainly one very important initiative. We cooperate, as you know, quite a lot as the EU. But of course, we need to do more, and we need to continue to do more because it's a priority for all of us. Let's be very clear. Now, on the question of, there was several questions linked to the question of compulsory licensing and the question of intellectual property right. As you know, the position of the Commission is simply we do not believe in compulsory licensing. I don't need to go into the details now. I mean, it's not for me to give you this explanation. It's clear, compulsory licensing we don't believe is the appropriate way forward. Now, we have this mechanism, these schemes of mechanism of voluntary licensing, which we believe could be an incentive actually for companies to take part of it and to make sure actually that they spread the knowledge and they help it. To some extent that's something which exists and has existed. It's not maybe not so widespread, but we believe we could try to work on it and try to make it more effective, I would say, from that point of view. But I agree the question of intellectual property right is a very important one. On the question of the relationship with the US and the links and export restrictions which exist in the US, you know it's a very sensitive topic. You also know that the President of the Commission talked to the President of the US to try to address this issue and to find a solution. We know it's sensitive, it's complicated. I don't have a magic solution, If I had one, I would use it, but it's something on which is very clear, a very high priority on the agenda of the Commission and certainly of the President and Mrs. Breton. On the question of partnership, public-private partnership, I want to be clear also on that because there is maybe an ambiguity in the way, and that's my fault, in the way I presented things. It's clear that what we want is cooperation, but we are not creating a formal partnership as such. So we are not creating at this stage, maybe in the future, if you agree, in the context of HERA. But at this stage, when people are talking about partnership, it's more cooperation. Reinforcing the cooperation between the private sector, the public actors, and scientific dimension to make sure that all of us we work together to achieve the target, which is to avoid to be in a third crisis because of the COVID variants. So that's the way. So it's not a formal partnership, public partnership. It's more just a way to work together. But we believe it's important. And of course, the question which several of you has asked, and it's linked also to the APA. It's clear that we have APAs with a certain number of countries, number of suppliers. So it's clear, of course, we will continue to work with them because they are there, of course, clearly. But the door is not closed. And so to come back also to one of the remarks which has been done about, non-profit organizations which might have developed solutions, again, the door is not closed. So if some people have solutions which could be of interest, of course, let's come and talk to us, and we are willing to see whether we can do. I'm not making a commitment nor a guarantee, but I believe that's something which is important. On the question of transparency and the fact that you believe it's important, I agree. We all agree on that, and I don't want to repeat a debate which has already taken place in this context quite several times. One element also I want to be clear. HERA incubator is a test case for HERA, but of course for HERA itself, we are conducting a full we will have an impact assessment, we are conducting public consultation, and of course we will have a legislative proposals which will be submitted to you after the summer and for discussion, of course, leading to a possible solution. So we believe, HERA incubator is a short-term reaction to a very urgent problem, but of course, HERA will have a different scope. For instance, will not only deal with the question of COVID, but will be much broader than this. A question also, are we necessarily going to conclude new contracts? No, not necessary. Of course, if we have already a contract with the company, we could base ourselves on the existing contracts. But as I say, we don't close the door. So if someone has a magic solution, has a solution for new variants, which, in the future, we should be open. So we should not say simply we work only with those who exist and which we have a contract. On Vaccelerate, on the member states and to be honest with you, I don't have the exact list, but I can make sure that we send you the list of the partners and the countries which are there. So it's 21 member states and 5 countries which are outside of the EU. But I would prefer to send you the list to make sure, rather than saying something which would be wrong. But it's clear, of course, that the question of voluntary participation on a cross-border basis is a difficult one. I don't have a magic solution, but that's an issue that we need to address and to tackle in this context, because I believe that's something which is important. Maybe last point on which I would like to insist, on the question of the sequencing and the 5% as a target. Again, the 5% has not been invited by the Commission. It's something which has been invited by the experts, saying, that's the minimum you need to have a clear understanding of the situation. What we want to do simply, some member states are able to meet this target, some member states are not able to do it. So that's why we want to put money on the table through the ECDC to make sure actually that we provide facilities to those member states which for the moment do not have the capabilities to do the 5% sequencing. So basically, how does it work? It's just a laboratory which is there, and where member states who would like to get their samples to be tested are free to send their samples to this laboratory to do the sequencing. So that's exactly what we want to do. So it's just helping member states to achieve the target. I believe I should stop here, but I don't see the clock, so I have no idea if I've been too long or not. But I would stop here maybe, and thank you very much for your attention.
Thank you. So we will be very happy to see the legal base for the very short-term next step, and we will be also ready to move forward very soon on the HERA response. Thank you very much. We close this session, and we will see each other a bit later on this afternoon. Before moving to the next session, I have to formally declare the vote open on the amendments of the draft opinion on the protection of workers from the risk related to exposure to cancerogen or mutagens at work.